As Avril says, I'm an endocrinologist. I'm a doctor who specializes in diagnosing and managing hormone problems. So outside of neuroendocrine tumors, that's a lot of thyroid disorders. We have a gland just below our brain called the pituitary gland, lots of those kind of problems. But when it comes to people with neuroendocrine tumors, an endocrinologist can be helpful if a person has a neuroendocrine tumor that produces hormones, or for a person with a neuroendocrine tumor who has a lot of symptoms that could be due to hormone secretion. Having an endocrinologist come along and try and actually sort out the cause of the symptoms can be quite useful as well. So the first question was, what's the probability of NET patients' children's getting neuroendocrine tumors? And is there any checkups that NET patients' children should undergo for early detection? So I just wanted to go back to just kind of thinking about what happens with inheritance. So when we're talking about the kinds of genes that cause tumors, you usually only have to have one of the gene to be a person predisposed to tumors. So here, for example, we've got, in this case, dad has the gene, mum does not have the gene. So if you've got this blue gene, then you've got the gene, and purple is normal. So the dad has got one abnormal gene and one normal gene, and mum's got two normal genes. Then on the other side, just to even it out, because we don't want to be always blaming the guys, on this side, it's the same thing, but in this case, the mother is the one who's got the abnormal gene. So then for your children, they inherit one gene from the dad, one gene from the mum, and it's random whether or not they get a gene that is abnormal or normal. So from the mum, in this case, on this side, hopefully you can see you are seeing my cursor as well. From the mum, because mum has two normal genes, everybody gets a normal gene from mum. But you have a 50-50 chance of getting an abnormal gene from dad. So that's why you end up in this scenario of 4 children, we've got 2 with the affected gene and 2 with the normal gene. So just a reminder of how inheriting genes from your parents work. And of course, in real life, because everything in real life is random, you could, if things are not split down the middle, you wouldn't have necessarily 2 and 2, but that's how the genes are inherited. In the case of neuroendocrine tumors, it depends on what type of neuroendocrine tumor you have, whether or not your children are likely to be affected. So for those of you who have a small intestinal neuroendocrine tumor, then there's very few cases of small intestinal neuroendocrine tumors being inherited. So if you have a small intestinal neuroendocrine tumor, then as far as your children are concerned, they should be aware of your family history. I think anyone who's had any type of tumor should let their children know about it, because we are learning more and more about genetics all the time. But they should not be more likely to get a neuroendocrine tumor than just any other person. But for those of you who have a pancreatic neuroendocrine tumor, about 1 in 10 people with a pancreatic neuroendocrine tumor have a gene that they've inherited that predisposes them to having a pancreas neuroendocrine tumor. Now, that's usually reasonably, the family history in that case is usually quite strong. So if you're the first person diagnosed in your family, if you started asking around the family, usually other people have been affected either with pancreas neuroendocrine tumors or other types of endocrine tumors in other endocrine glands. So for people with pancreas neuroendocrine tumors, most of the time they will not be inherited. They've just happened randomly and we don't understand why they happen yet. If you are a person with a pancreas neuroendocrine tumor, it's even more important that your family is aware of what you have. So I guess, every family is different. I think I've said this before in a Zoom group. I know all the health conditions that everybody in my extended family have, because they all, whenever we catch up as a family, they'll all tell me what medications have started and whatnot. Whereas on the other hand, despite the fact in my family we have a lot of heart disease problems, I can guarantee you that my younger brothers will have no idea what kind of health conditions are in our family. So people have a varying kind of level of interest, but it's important if you are a person with a pancreas neuroendocrine tumor that you do kind of let people know that that's what you have, because that's when you start piecing together what's actually going on in your family. So most likely, if you have a pancreas neuroendocrine tumor, you've most likely it's very random that it's happened to you. But for the occasional person, it is inherited, but that's usually there will be a family history. And once you asking around, you'll find that other people have had the tumors as well. For people with PHEOs and paragangliomas, they're at the highest likelihood of being inherited. So we actually recommend that anyone who's had a PHEO or paraganglioma has a gene test done. So we wouldn't do gene testing on a routine basis for people's pancreas nets, but for people with PHEOs and paragangliomas, everybody should get a gene test done. And there's quite well-known gene test panels to do for those to pick up the variety of genes that can cause those. So going back to the question in regards to your children, regardless of what type of tumor you have, it's just good if your children know what you have for a variety of reasons. But in terms of the risk of inheritance, it's just good for them to know about it. There are other, of course, less common types of neuroendocrine tumor, and whether or not they're associated with inheritance depends on the individual type. But usually a inherited syndrome will have a strong family history. Usually, if you ask around through the family history, it will be identified. So someone's just asked about MEN1. So MEN1 is one of the inherited causes of a pancreas neuroendocrine tumor. So if you are a person who has primary hyperparathyroidism and a pancreas neuroendocrine tumor, or if you're a person who has, I think the question said about pituitary adenoma and a pancreas neuroendocrine tumor, then you should be tested for an inherited gene that's present to those. And similarly, if there's a family history of people having those tumor types as well. So there are small intestinal neuroendocrine tumors have very rarely been associated with a family, but if you have a very strong family history, it's very uncommon for people with small intestinal nets to have another family member with a small intestinal net. So if you are a person who that does apply to you, you've got more than one family member with a small intestinal net, then it would be important for your oncologist that you could be referred to the genetic service to have that family tree put together and gene testing looked into. If it's for small intestinal nets, because the genetics of it are not well understood, you would potentially be able to participate in in more of a research based thing, which is not straightforward to organize. So if you are someone who has got a family history of small intestinal nets, it would be important to get tied into the genetic service so that that kind of gene sequencing, it's potentially a new gene that's not previously been identified, hopefully that makes sense. Like, for example, for these pheos and paragangliomas that I've been talking about, there are a number of well-known genes that are identified. So we have a straightforward panel. If someone has a pheo or paraganglioma, we can just request the gene panel in the sample. It does get sent overseas, but it gets sent overseas for a lab. Similarly, for MEN1, we know what those gene mutations are, so we can test for those. For the small intestinal nets, we don't know what those genes are yet. So gene testing would have to be done on a research basis, which is a lot harder to just organize, and would need a lot of coordination with your oncology team and genetic service. So if that does affect you, it would be important to alert your oncologist to it. And it can be hard to get that kind of thing going because people are like, oh, how do we search for new genes? So it would be important to just also keep pushing on that. And when we have, at the moment, we are not doing any gene sequencing in this type of setting, but on the odd occasion, we do have research done. Can it still be done though? It can still be done. It's just really hard to organize. So what would be the best way forward, I think, since there's a really strong family history, is for the oncologist to get in touch with the genetic service to try and get the family history. Sometimes, for example, if you don't know whether or not someone had a small intestinal net in the past, if we're able to identify who the person is, then through the genetic service, we can get access to records. So it would be a matter of keeping on pressing your oncologist to get you tapped into the genetic service to find out as well whether or not there's any research projects going. So as I said, actually right now in New Zealand, we don't have, we're not doing a research project doing sequencing. We have done them in the past and we will do them in the future. So it's just important to, it's definitely, if it's not a known gene, it's not that straightforward, but it's not impossible. I think that's about as good as I can probably answer this evening. But if it looks like there's something inherited in your family, I think it is important to keep pushing forward with your oncologist and genetic service to keep you tapped in, so that you can be aware of when any research-based stuff is happening, so that you can get tapped into that straight away, so that you can get gene testing done. Hopefully that answers that question. That's quite a tricky one. The next question was, what test should someone with a pancreas net living with diabetes undergo to investigate sudden and sporadic blood sugar drops? So number one, this person should be under an endocrinologist. So if you have diabetes, you should be under, that's a definite reason for being under an endocrinologist. And the testing that needs to be done in this setting, there's kind of multiple things that need to be looked at. First of all, you would want to look at, does it relate to your diabetes management? So are you on insulin, and is the way that you manage your insulin not optimally managed? So for example, using the example of exercise, if you know you're going to do a lot of exercise, you sometimes need to drop the amount of insulin you're having by sometimes 50%, depending on who you are. So the first thing would be to look into, how are you giving yourself insulin, and are you just not on the right amount of insulin? And also for anyone, I'm not sure if anyone here is on insulin, but if you are on insulin and you keep injecting into the same spot, it will start affecting how your insulin is absorbed. So that's why for the people on insulin, they have to move. And this is very specific to some very specific people, but they've got to move it around where they inject so that they get nice, even absorption of the insulin. So that would be the first thing. There's lots of things around the diabetes. But if you have a pancreas net and you have diabetes, and on the odd occasion, a person with a pancreas net could develop an insulinoma even if they had a past history of diabetes. So that an insulinoma is a pancreas neuroendocrine tumor that produces extra insulin. The other thing that could happen, and that would require specialist testing to get that diagnosed. The other thing that can happen to a person with a pancreas net is that they don't make the enzymes that digest food properly anymore. So that can really affect if you are a person with diabetes and you don't have enough enzymes to help you absorb the food well, then you can have less even control. So sometimes high, sometimes low sugars, because you don't have a good absorption of the fat and the protein with your meals to try and even out your blood sugars. So there's a few things that can go on with someone who's got diabetes and a pancreas net. Most likely it relates to the management of the insulin, but you definitely need good endocrinologist input to sort that one out. I think there was also a question in the chat about the risk of carcinoid crisis with minor surgery. So if the surgery was a minor surgery, for example, the removal of a skin lesion, and you have carcinoid syndrome, but you are on octreotide and your symptoms are well controlled, then that should not precipitate a carcinoid crisis. So it's more with major surgery that we could get concerned about carcinoid crisis. Such as if you're going to have major abdominal surgery. And the interesting thing about the risk of this happening is that people seem to get through very major surgery with carcinoid syndrome and not have a carcinoid crisis, and other people have a carcinoid crisis. And it just seems to not necessarily have a great rhyme or reason why people seem to be able to get through procedures without having a carcinoid crisis, and then other times it doesn't occur. So to answer the question in the chat, I would say if it's very minor and you're on octreotide and you're going to have something like a skin lesion removed, you'll be fine. If you're having major surgery, then you do want to protect yourself. It's unpredictable whether or not you'd have a carcinoid crisis, but to protect yourself from having one, the anaesthetist should be putting you, and they will be because they get worried about this as well, on the octreotide infusion before you have your surgery to manage around this. And I have not so far seen anyone have a carcinoid crisis after surgery, I think because people tend to be managed really well around surgery, which is a good thing. I think in regards to the second half of this question, should people with carcinoid crisis wear medical alert bracelets to not be given adrenaline? I think that's not a bad idea. I think the medical alert, I don't know if anyone, maybe someone can mention in the chat if they have got a medical alert bracelet. I think they're quite, it's maybe a good idea. They're internationally recognized. So if you're somewhere where you're overseas and I don't know, something happens to you and you end up having to go into hospital, then maybe it's a really good idea to have a medical alert bracelet, not just so that you don't get given adrenaline, but just overall for carcinoid syndrome management. It's kind of, I think, a good safeguard. Like anything that's a good safeguard is a good idea. I think it's a good idea. I think consider looking at it. I have a patient who has instead of getting the medical alert bracelet, they got basically the medical alert bracelet tattooed on their arm. which kind of, I think it's a pretty cool symbol. So if you're someone who likes to have tattoos, then I think that's kind of like a, nice idea.
Is there any risk for people going and like, is it the anesthetic or is it the actual procedure? Because like for dental work and having anesthetic for that.
It could be either or. So if you're just having local anesthetic, like the lignocaine anesthetic, that shouldn't be enough if you're someone who's got well-controlled carcinoid syndrome. Same with the skin, you'll be injected with local anesthetic. The local anesthetic should not trigger it. What they're giving in terms of like a general anesthetic is different to what's given in the local anesthetic. And not that much gets absorbed into the body with a local anesthetic for either your teeth or for the skin. So it's not at that kind of level where you've got a risk of carcinoid crisis. Yeah, but I think it's definitely a good idea, the medical alert bracelet thing. And I don't know why I don't know, do it for other people, like for people with a low cortisol. So I don't know, just haven't really, I think it's a good idea. We should start at least talking about it, and maybe get some of the, someone's shared the website, but there's also like brochures. We have them in our endocrinology clinic, but we don't have them in the oncology clinic. So maybe we should think about that. I think this is the last question. Is there a test you often do as an endocrinologist that you notice medical oncologists don't do as often when looking after NET patients? I really like this question. The funny thing is, I would say, is that it's more to do with probably the tests that I would do more often are tests that are not hormones, to explain. Often people have had hormone testing, and then I'll be like, these hormones are not explaining what this person has got. So then I'll look for other things. So I guess in terms of looking for other things that are not the hormones to explain the symptoms, I think I would definitely do more often than the medical oncologist. Testing for diabetes, I do a lot more testing for diabetes, I'm going to say. I would say oftentimes people don't get diabetes testing done, and it is really, we use a lot of steroids as part of our treatment, but obviously also people's pancreas nets can have diabetes, so it's a really important one to look for. I always test for calcium. I would say oncologists would test for calcium probably most of the time, but I think we're probably testing for different reasons. So I think someone mentioned earlier a condition called primary hyperparathyroidism just in the chat. So there is a gland in our neck. So I think a lot of you have probably heard of the thyroid gland before. There are these little glands that sit next to the thyroid gland called the parathyroid glands, and they control the calcium in our body. And people who have inherited a gene that can cause neuroendocrine tumors will often have primary hyperparathyroidism. So they'll often have a high calcium. So I would say that that's probably, I would probably look for that more often, I'm going to say. I think, I don't know that, I think in terms of the hormone testing, there's probably some particular hormones that I would probably potentially look for more than the oncologists, such as there's a hormone called calcitonin that I probably look for more often. Think it causes similar syndrome to carcinoid syndrome. Oh, one test I think I definitely do more often as well is the 24-hour urine 5-HIAA. So that's probably very annoying to be asked to be doing one of those, but sometimes you all need a day staying at home anyway, so that's a good excuse. Stay at home and collect your urine. I think that's what I think I probably would ask for that more often. I know it's an annoying test, and hopefully if I keep getting more research money, then I will try and figure out a better way to do that test without getting you to do 24-hour urines all the time. But yeah, I think it's a good thing when you have a complicated condition like a neuroendocrine tumor, although maybe it gets confusing to see lots of different types of specialists, but I think we all have a different kind of angle when we look at things, and we all think of things kind of differently, and we pick up on different things. So yeah, there's definitely a different, I guess, in terms of the things that we concentrate on, a bit of a difference between what I do as an endocrinologist and what medical oncologists do, which is why if you need both, it's good to have both. That was all the questions that I had. I think I'll stop the share. Not that I had much, so I'm sorry about, I actually intended to have more diagrams, especially with the question, which I really liked about asking about the diabetes question, because I feel like that's hopefully one thing as an endocrinologist can be helpful to help managing from the diabetes side, but it's quite complicated to explain without having done diagrams. So I'm sorry for being underprepared, but it's because Avril called me 100 times today.
I'm sorry, everybody. It's all my fault. You will be pleased to know that if you aren't under an endocrinologist and you do get your consultants to review your cases at the National MDM, Veronica chairs it every other week, I think now. So she definitely gives her input and advice from an endocrinological, is that the right way to say that? Point of view. So that does get feedback to your consultants if you aren't under an endocrinologist. So don't panic if you aren't.
Yeah. Someone asked about how long genetic testing is taking at Peter Mac. At the moment, we're tending to send a lot of our gene testing either to Finland, Germany, or the UK. So that does mean that the samples go quite far. And they're usually taking about 6 weeks to get back, I would say, maybe 6 weeks to 2 months. Just in terms of like, we send them there because we want panels that are, have lots of genes on them, but yeah, I guess Peter Mac must be charging, maybe they're charging a bit more than the UK guys at the moment.
But it's really great to have you along, and I know there's a few people on tonight's chat that specifically came on because of the questions that were sent in. So thank you very much for taking the time to answer those questions for everyone, and no doubt we'll have you back in the future anyways for more questions.
So hopefully I've answered those questions, because they were really great questions too. So yeah, feel free to ask them again if I didn't answer them adequately this time.
Thank you. All right.
Bye, everyone.
Thank you, Veronica. See ya.
Thanks, Veronica. Bye. Bye.